Good afternoon, everyone, and welcome back from lunch. My name is Beth Connor, and I'm a nurse informaticist in the Emerging Innovations Group within CMS's Office of Burden Reduction and Health Informatics. Today, I have the pleasure of welcoming Dr. Richard Shannon as our next speaker. Dr. Shannon serves as the Chief Medical Officer and Chief Quality Officer, as well as a Senior Vice President at Duke University Health System. Prior to joining Duke Health, Dr. Shannon worked at the University of Virginia's health system as an executive vice president for health affairs. Dr. Shannon has had a long career in the academic field, serving as chair of the Department of Medicine at the University of Pennsylvania and as chair of the Department of Medicine at Allegheny General Hospital in Pittsburgh. He has received a number of teaching awards from the medical schools of Harvard, Drexel University, and the University of Pennsylvania. Dr. Shannon is also an elected member of several honorary organizations, including the American Society for Clinical Investigation, and previously served as a senior fellow of health economics at the University of Pennsylvania. He is currently a member of the board of directors of the Kaiser Foundation Hospitals and Kaiser Foundation Health Plan, where he is chair of the Quality Health Improvement Committee. His innovative work on clinical quality and patient safety has been featured in the Wall Street Journal, the New York Times, CNN, and more. Please welcome Dr. Richard Shannon.
Thanks very much for that kind introduction and good afternoon. I appreciate the opportunity to spend some time with you today, and most importantly, am energized by the large number of people that have joined us for this really important conference to examine what we can do about the overburdened healthcare workforce. Next slide, please. So I want to begin by sharing with you just a brief account of what I call the arc of history in healthcare quality. It really dates back to the Oath of Hippocrates in 400 BC, an oath that even today health professionals attest to, often at the time of matriculation. Fast forward a mere 2,400 years, and we come to the seminal work of the Institute of Medicine at the turn of the century, crossing the quality chasm into Air is Human. Fundamental pieces of evidence and work that were ushered in by what were being recognized as all too frequent tragedies that occurred in healthcare systems to innocent patients through the infliction of unintended harms. And then if we look at the next 20 to 25 years, I think it's fair to say that much of the quality system in America has been characterized by an ever-growing litany of public reports. And those public reports share 5 common characteristics. They're almost exclusively based upon insurance claims data, where the measures are determined by regulators and payers. They're often anachronistic, 6 months to as much as 2 to 3 years out of sync with when the reports are issued. They have largely been blind to social needs and the growing recognition of the role they play in health outcomes, and have been indifferent to the growing issues around health inequity. So the question becomes, in that 25 years where I think the system has largely been characterized by these monikers, what can we show as evidence of improvement? Next slide. Well, in fact, 25 years later, we see that actually the improvement can best be described as modest. And I list 3 references here. One, the work of David Bates and the Harvard CRICO group, which basically demonstrates that harmful events occur in 1 in 4 hospitalized patients. Noel Etheridge and Harlan Krumholtz's work in JAMA, which showed that basically there's somewhere between a 3 and maybe 6% reduction in adverse events over a decade of work that they studied in 250,000 hospitalized patients. And then more recently, the stinging editorial written by a group of patient safety advocates, pointing the finger at hospital leaders, particularly asking the question, who's killed patient safety? Well, the point I'd like to make today is I don't think patient safety is dead, but I think it is been buried alive in an ever-growing sea of challenging metrics, which are beginning to disengage the provider and patient community from the necessary work that we need to do to really muster the types of improvements to change these outcomes. Next slide. So what do I mean by a tyranny of measurement? Here's some data from my own experience at the University of Virginia. At UVA, we measured 484 safety and quality measures. We reported them to 8 different regulatory agencies. We spent $13 million on reporting and quality personnel. And we had 4 different ways, for example, that the mortality rates at the University of Virginia were characterized. That's just a brief snapshot. Recently, Johns Hopkins published their experience, and you see similar sorts of issues. At Duke, we monitor 596 unique metrics, and we have 136 FTE engaged in our quality and safety domains. So it's not as if resources haven't been put into this, but those resources have largely been focused heavily upon refining measurement and less upon engaging in improvement. Next slide. And this is an example of an interesting article, and there are many now that are emerging, which looks at this tyranny of measurement in quality and safety. This is from David Shaywitz in a paper that was an article that was published in Forbes, and it coins this term managerialism, which I'll read for you, is the belief that the right way to improve performance is to measure more, capture more data, and use data to micromanage. It's as if too many of our safety and quality people are spending their time looking at desktops and dashboards, hoping to find in the sea of measurement some answer that will drive improvement. But we all know it is the work process that leads to improvement, not more management. And my argument here today is that we begin to shift the balance more toward a preoccupation with improvement and less measurement. Next slide. Now, to that point, I want to illustrate that measurement documentation is a common cause of overburden. So we use this functional assessment to actually try to quantify workforce strain among our team members. What you see here are a number of parameters. For example, for a nurse, one could quantify their work strain based upon the number of patients they're attending to, the complexity of those patients, the number of tasks each of those patients require, the time it takes to complete each of those tasks, and then, of course, the burden of required documentation of much of that activity. That numerator, as the number of tasks and time it takes to complete each increase, compounded by fewer staff, and leads to steps being missed and increasingly shortened or eliminated work processes. That's just human nature when the burden becomes excessive. And in the denominator, one has to include the actual number of team member equivalents. We normalize this based upon experience, and with less experienced staff who may be somewhat exhausted, that creates an increased risk for communication failures, failures in transitions of handoffs, and missed or ignored information. Together, these changes in the numerator and the denominator are what are contributing to this dramatic increase we've seen in the peri and post-pandemic period, leading to delays in cares, misdiagnosis, medical errors, decreased patient experience, and working clinical outcomes. But it is the quantification of the work process that allows us to understand the root cause of this growing spate of harm, not better measurement. Next slide. So we've developed the Duke Quality System to create a leadership mindset that is focused really on these points here in the middle. That if we and other healthcare systems want better results for both our patients and our team members, then the only way you get better results is by looking at your structures, your systems, and your work processes. And that this idea of habitual excellence, which I learned at the knee of Paul O'Neill, the CEO of Alcoa, who transformed that to the safest place to work in the world. What I learned about habitual excellence from Paul O'Neill was that it is actually about developing people in continuous improvement, not about more measurement. So we must recalibrate the balance in quality and safety to put our finger on the scales on the improvement side and take our foot off the scale on the measurement side. Next. So how have we done that? We've developed lean management principles, which we've implicated across our organization as a disciplined scientific approach to improvement. It's comprised of three separate systems: a management system, which is created first, which creates daily situational awareness at every unit in every clinic across all of Duke Health. We use tools there that allow team members to understand the situational awareness: who has central lines, who has Foley catheters, who is a falls risk, where are there high risk medications being delivered, where that might be staff shortages that could create gaps in clinical care. The work system, to my mind, is the most essential part of the improvement system, because if one can't standardize and stabilize work processes, then one has no basis against which to compare performance. If there is no standard to the way a system of care is delivered, you cannot identify the gaps in care. So understanding the work process becomes essential to the work of fixing that work process to get better outcomes. And then, of course, the tools of improvement, which are the PDSA cycles and the other lean management capabilities that allows one to identify a gap and to use a scientific method to improve it. Next slide, please. So as I said, this idea of value stream mapping is a frontline team member engagement. And this is an illustration of an exercise in which we value streamed map the episode of care involving patients who had a stroke at Duke. So believe it or not, there were 139 different steps that we could map out within the first 48 hours of care that a patient in our unit for stroke received. And we found as many as 67 gaps in that process of care that included duplication of efforts or incomplete work or lack of appropriate connection or lack of work specification that led to misunderstanding and delays that could compromise care. But the idea of bringing the people that do the work to an exercise like this and having them illustrate what the process as it exists in the current condition is an invaluable way to create agency and voice for the people that do the work. Next slide. It is critically important that we make direct observations of how people spend their time. It is remarkable how often we as leaders assume we understand how people spend their time. But this is more than 200 hours of observing nursing work at Duke Raleigh Hospital, where we observed every unit 24 hours a day for at least 3 days and tried to quantify all the different activities that a nurse was asked to do. And then working together with our Duke Quality System lean management coaches, we quantified whether the work was deemed to be value added, meaning it added value to a patient. Said differently, someone might actually pay for it. That it was not value added, but required, a regulatory requirement, and that's in yellow here. And then red are all the things that the team members and the lean management teams agreed were just waste, no useful purpose. What you see here is that 4.5 hours of a nurse's time out of a 12-hour shift at Duke is spent documenting. Less than 10% is thought to be value added. 4 hours of documentation. And about 35% of the total nurse's day, 12 hours, is thought to be red or waste. Now, if you want to understand what to do to fix the overburdened nurse, it's not about feeding them more or patting them on the back. It may be paying them more, but it's fix these problems. But if you can't quantify them, you can't illustrate them, you can't identify them, then you can't improve them. Next slide. So I'm not going to go through this in detail, but we have launched these efforts across all of Duke Health. About a third of our inpatient units now are these model areas where 7 or 8 care redesign processes put in place. I'm going to highlight just for a second here resource nurses role. So on our stroke unit, we have 42 beds, 14 nurses, 13 nurses. So the average nurse taking care of 4 patients. The nurses said, we don't want more nurses. What we'd rather do is actually take an extra patient and have one of our colleagues serve as a resource nurse for 3 or 4 of the nurses that are actually are working directly in patient care. I'd rather have a help chain that I can pull for when my work process is stalled than to actually have fewer patients. I'd rather have someone I can pull for when a patient decompensates so that I can still get the discharge done or still get the medication delivered than actually do less of an assignment. So we redesigned the work where we created 3 resource nurses for 3 or 4 nurses across the 42-bed platform. And what happened? What happened? Here are the results. 6 months in. Next slide. This is 6 months of work. We saw a 41% reduction in harms. We saw 9 out of 14 categories in our HSCAP4s top decile performance and 3 others top quartile. We saw nursing satisfaction scores on this unit that were the highest of any unit across Duke Health. Let me say, this work was done in 2021 in the heart of the pandemic. And this unit had the lowest turnover rate of any unit at Duke, 9%. Next slide. We saw the average length of stay for stroke patients decline by 1.7 days. We saw the pay FTE and work FTE favorable to our flex budget. Only $1,200 of temporary labor spent in a 6-month period. This is in the pandemic. And the work hours per unit of service were favorable to budget, only a 9% turnover rate. And I didn't include here, but stroke mortality at 30 days went down from 10.5 to 9.6%. Every category of quality, safety, experience, and engagement improved by redefining the work. Next slide. Now, I want to conclude by sharing with you that these very same ideas of focusing on work process improvement can apply equally to the daunting task of reducing health disparities. And part of this work is in what we call the Collaborative Advanced Clinical Health Equity at Duke, where we've agreed that we will look at every clinical outcome through the lens of race and ethnicity, identify 7 key performance indicators that are driving that disparity, and then use our improvement methodologies to address the countermeasures. Next slide. So we have data at Duke. This is a Tableau dashboard which illustrates more than 42,000 maternal deliveries at Duke over a 7-year period. This illustrates the number of maternal morbid events that are updated every day in real time. We stratified these data by age and parity. We stratify it by race and ethnicity. We stratify it by comorbidities, not illustrated on this particular Tableau shot, by insurance status, by type of delivery, by social needs, by access to care, and then we define each of the morbid categories that moms experience. Next slide. I'm going to skip this one and just go to the next one in the interest of time. So what did the root cause analysis illustrate with respect to disparities in maternal morbidity at Duke? So we found that, in fact, there was no difference in age or gender, but in fact, African-American moms were 1.6 times more likely than white moms to experience a complication in pregnancy. How come? African-American moms turned out to be twice as likely to have hypertension and diabetes as pre-existing conditions and to experience anemia in their pregnancy as well as preterm labor. African-American moms tend to have more Medicaid insurance compared to white moms, which were more commercially insured. African-American moms were 2.2 times more likely not to show for a maternal visit and 2 times more likely to use the ED or the labor triage visits instead of ongoing maternal care. African-American moms at Duke had higher rates of transportation needs and food insecurity. Next slide. So then you do a root cause analysis. Why are African-American moms bringing a greater burden of comorbidities to their pregnancies? Well, the majority of these moms had pre-existing medical conditions that heretofore had received no medical attention because they had no access to care. And many of these moms didn't lack access to food, but lacked access to healthy food. particularly important in the course of their pregnancy. Why did African American moms miss so many prenatal visits? Well, it turns out that it takes 3 bus rides from East Durham to get to our high-risk Irwin Road clinic. 56% of African American moms made their first third trimester visit, a pretty clinical visit. 56%. Well, and I'll tell you what we discovered there. It turns out that we weren't scheduling commensurate with the bus schedules, and most of the African American moms had to take buses to get to our clinic. So we reorganized the schedule to correspond with the bus service and made some other modifications. Turns out if you were 30 minutes late, we said you had to reschedule. Well, if you take the bus, it's far more likely you're going to be 30 minutes late. So we changed that policy, improved the throughput in our clinic. We're able to get our staff out on time, but still see any mom that came, no matter how late they were. Next slide. So in order to deal with the greater comorbidities, we created care coordination for moms. We had 2 nurses that basically took moms with pre-existing conditions under their wings and made sure they got connected into the Duke specialty care systems to manage those complications, to manage those comorbidities during pregnancy. And we developed a culturally competent midwife program to assist these moms during the course of labor. As I said, we changed the scheduling practices, gave preferential priorities to moms of color that had to travel by the bus, and we went from 56% of these moms making their first third trimester visit to 86% of the moms making those visits with those changes. We also initiated virtual visits and remote monitoring. Next slide. So if you change the work and improve the work process, can you reduce maternal morbidity? This is data over the last nearly 3 years now. This is the baseline in 2020, 2021, 22, and 23. This is the overall 35% decline we've seen in maternal morbidity, a 34% decline among white moms, a 48% decline among African American moms, and a 19% decline among Hispanic moms. So do we have to tolerate racial injustice and health disparities? No. It isn't solved by more measurement. It is solved by more improvement. Next slide. So I'd like to conclude by saying I do think it's time to reimagine the quality system in the country 25 years after the Institute of Medicine reports. And I think that reimagination has to turn us from what has become this preoccupation with measurement and organizations trying to figure out the measurement, how the measurements are contrived, and changing the goalposts all the time, and all the working definitions, moving away from that fixation to a preoccupation with improvement. Because unless one is fixing the work process, one can't change the outcome. Thanks very much.